Hey everybody, let's talk about what a ecosystem that is a care ecosystem that could possibly work combining health, disability and aged care together. Now, just for a little bit of context, and for those of you that don't know me, my name is Jackie Grant. Now, this is all about thinking about how can we improve, here we are in 2025, how can we improve the outcomes for people in hospital, people living with a disability and our aging community? How can we spread the money that we have that's in health, disability, so that includes NDIS, and also aged care, that it actually benefits everybody and that it's a little bit more of a system that actually works in interconnecting. So one of the things that I've come up with is that a really good care ecosystem in health, disability and aged care, whenever I say disability, I want you to think NDIS as well, is a holistic system that integrates all the network of services, supports the people and the systems. So when we talk about each different part, this is where there's different governing bodies. There's different people saying, yep, we deal with this aspect of it. So, for example, NDIS, or we deal with health, or we deal with aged care. You can have those governing bodies separate, but you can also have a system that actually would interconnect a little bit more. So what would that look like? So an integrated support network is where we have healthcare providers such as our GP, our specialists, nurses, allied health professionals, surgeons, like that I suppose acute setting of people that are there at the forefront, helping you to get better, helping you to get the best healthcare that you possibly can. And then we maybe fit into that a little bit of rehab as well. And when something becomes a little bit more chronic, now we're starting to look at what other systems do we need to connect people into so that they can continue to have the best quality in their life as possible. Things like having coordinators, navigators, care managers, care coordinators, case managers, nurses and allied health professionals, as well as social workers, historically have done really well in these roles, especially when we're looking at combining health and disability, so NDIS and aged care. If there's going to have like those care coordinator, navigator role across it, all of those, they're the kind of people that you want. And I used to do a role like that. I did it in GP, I did it in community health, and it was a really rewarding role when it worked and we could get the people the amount of support that they needed, transition them from like a really acute phase into supporting that long-term journey for them. It was really great. Disability support workers or personal care attendants that have some qualifications, and lived experience is great as well, but having that little bit of qualifications actually helps them to be able to work in a variety of ways rather than just in one area. And when people are in one area and they start to get burnt out, it can be really hard to transition them to another area, especially when pay structures are different. So if we were to streamline it, imagine how much better that could be. Aged care providers as well, and this is where support workers can fit into that as well, or personal care attendants. They have the qualifications and training to understand aged care, disability, even in-home services where it comes under TAC and things like that. I know that we're getting into a little bit of private sector bit as well, but just people that have those qualifications that can work in a variety of areas. I think we would maybe find job satisfaction a bit better in these areas of combining them, things like that. And then the way that we support the families and the informal support of people that are living with ongoing health issues, ongoing disability, so those lifelong challenges that they face, whether it's mental health, things like that. I just want to put in this integrated support system, the mental health team as well. I think that if we could look at mental health a little bit more and incorporate that a little bit better than we currently are, I think we would find that we would have better communication between the acute sector. Then when a person's an inpatient for mental health services, as they're coming back out into community, and if it's classified as a disability, you know, if they're on NDIS, how are we supporting them? How are we supporting the person that's aging, so going over 65, and when placement and things like that is a bit of a problem? And how are we supporting family with things like dementia and that really want to keep people in their home for as long as possible? Remember, dementia, ABI, strokes, they can happen at any age. So this would allow for that connection. If we look at a system or an ecosystem that has that person-centered approach, then we could look at how individuals are the center of that. Now, when I do business coaching, I always get the client in the center of the situation. And then we build around that. So when I'm doing coaching with somebody, this is the exact model that I would use with them. They're in the center. Okay, so you're the center of this, and then how does this impact you? What services do you need right now, and what might you need in the future? Can we do a bit of planning and preparation and thinking about the what ifs, and how easy is it going to be to move people through those different stages of their life and different support needs that they may need, from acute to chronic and ongoing. And as they age as well, like, how can we support them in the most seamless system possible? One suggestion is we bring all this together. Services that are tailored to the person's goals, their preferences, cultures, and needs, so including neurodivergence. So how are we actually communicating with people who are neurodivergent, but they don't see themselves as having a disability? People with mental health conditions, how are we communicating with them? How are we communicating with people that have hearing impairments and also vision impairments? Like, is our language that we're using easy to understand for all people? And then what about people that have those chronic fatigues, that some days they just have that brain fog? Is the information easy to access in different ways? So is it audio? Is it not just an easy read, but audio? Those kind of things. So how are we communicating? Are we taking into consideration that when a person says, I actually want a white person that speaks English or Australian, I know, just go with me on this, and they're being really specific, then and I want a female, and they're not being discriminative of men, of people of different cultures or different race, anything like that, different colors. They're not being discriminative. It's just that their way of connecting with people and the way they feel safe is this kind of a person. Just as if someone said, I want somebody that is African American, or they're Italian, or they're Greek, or they're whatever. I want a female, I want a young person, I want an older person. It's not about discrimination. It's about that person and how they feel safe. So if we can take that into account, that would be really amazing. And when we're doing appointments with people, listening to them, how do you like this information communicated to you? Is text message okay? Is video call better? Is a phone call better? Like, how much notice do you need to prepare for this appointment? And do you need a few reminders? We're not taking away the responsibility of people. We're actually working with them in how they need it. If we can be a little more inclusive and we lead the way in health, in disability, in DIS, and in aged care, and we do this well in Australia, imagine how then we could go on to be leading the way in this system that is supporting our people here in Australia. Supports that aim to build independence, dignity, and well-being, as well as that quality life, and empowering people, and where possible, building capacity. It's not always possible, but where possible, being encouraging, being positive, but listening to the person. They don't want to be encouraged today. We just go, yep, sure, that's cool. Where are you at? What's going to work for you? That kind of thing. Number 3, interconnected services. So if we have medical supports, mental health supports, NDIS, my aged care programs, housing, transport, employment support, all those kind of things, even as people are leaving school. So with NDIS, there's the SLES program. In NDIS, there's the DES program. But what if we had that for other people that have gone through a chronic disease and they're starting to get on top of that? Like, how could the GP help liaise them into something that might be foundational supports or something like that? Nurses in GP clinics can often actually do a great job with that referral, but also if we had navigators or care coordinators, whatever name you want to give them, support coordinators sitting in GP clinics, that would actually help that support system and referral system as well. So it's how we connect people to all the different services that they need, and actually having a coordination service where it's like, yeah, okay, so I understand NDIS, I understand my aged care, I understand health. This was the role I did at the early stages of NDIS rolling out and my aged care rolling out. This is actually the role I did in a GP clinic, and it worked really well. And because of my nursing background, we could actually then do other things in the clinic when we didn't have a lot of that. Now, remember, it was the early days. So probably now if I was sitting in a GP clinic, I wouldn't have time for anything else. But there's also that little bit of coaching model as well, of empowering people and saying, don't worry, we'll send that in the mail, or we'll email it to you, or we'll text it to you. So having those communication ways to connect people to services. So when something does go wrong or they decline, getting them into their specialist could be a lot easier, potentially saving a little bit of money because the systems are all talking to each other. So things aren't getting lost. But also, obviously, confidentiality is really important with all of this as well, and privacy legislation. You've got to follow all of that. Number 4, having policies, funding and governance that actually work together, that nobody is being sacrificed for the other, right? So systems, so we can still have primary health networks, we can still have the My Aged Care, we can still have the NDIS, but let's look at our governance of all of this. Like, let's look at what is working, like what's working in health that could be adopted by NDIS and could be adopted by My Aged Care. What's working in My Aged Care that could be adopted by the others? What's working in NDIS that could be adopted? Do we need to have an accreditation system and a compliance system that is maybe tiered, but because it's tiered, it just means that it's universal in a way? So there's certain governance for certain things. So hospitals have to meet certain things, GPs have to meet certain things, so on and so forth, aged care and NDIS. So there's certain key points for each one. But if it was a tiered system, and I know that the aged care one, the proposed one's coming out with, a registration fee and an audit fee, I think it was. This is, I think it's looking around $18,000 or something like that. But looking at how that could work, and then it's on a volume, so the audit for a big hospital costs a lot more than an NDIS, very small company. So proportional fee structure, proportional in the way that we actually look at how can our compliance be very similar across the board, which gives us in our workforce, remember, that little bit of our flexibility of our workforce moving in between all three where possible. Just an idea. These are all just ideas. So looking at, our regulations and our funding models, our quality standards and compliance frameworks, our complaints management systems, our risk management systems, our incident management systems, and then, of course, our banning systems of when somebody has done something wrong and they've been investigated and it's, quite a serious offence, that those banning orders or restrictions come into play. So AHPRA has some things that really work really well. ESSA has some things that work really well. Like, let's have a look at what's working and is it adaptable to go across all the streams, and how would it work and what would the cost be to the service provider. These are all just ideas. Number 5 is those community and social inclusions. So incorporating community groups. Now, this is really where foundational supports could come into play. Things like social enterprises, education for providers, peer support for the participants, peer support for the staff as well, networking and advocacy services that we already have, but how can we support them a little bit more to not get burnt out? Having opportunities where people can actually go and feel welcomed and part of community. One of the biggest things that I noticed with people when they came down to the GP clinic or they came to the community health centre, we got them out of their home. And that might have been the only thing they did all week to be able to get out of the home. And then some of them used to all catch up and have a coffee. It was really amazing just to see them, to be social. And they shared, this is my one outing and I look forward to it once a month to come down and see the doctor, and then I see the physio, and then I go and have a coffee and I meet the same people, and it's just really nice. And they always ask for the same appointment time, and, where we could, we accommodated it. So those kind of things can make a big difference to the quality of somebody's life. Sometimes it's the little things. So this is where foundational supports could probably come in and fit into this. Now, why is all of this important? So a well-functioning care ecosystem reduces duplication and the gaps in services. So it's often we hear this with NDIS is that, no, NDIS is paying for that. Well, actually, no, they're not, because I didn't get it in my funding. But you have NDIS, so we're not going to offer that service. So the person falls through the gaps with some services because it's like, well, you have an NDIS plan. Why aren't they covering it? NDIS says, no, that's medical. And then the person's stuck in the middle not getting the service. In some cases, there is a duplication where people will go use an EPC plan and then they'll continue on then with NDIS funding or my aged care funding. So this system, if the system and the funding allocation is working properly and the systems are working properly with that overarching navigation support, care support, coordination of services really working well, so that's really nice and tight, then what could happen is that, and the staff can move across all sectors, parts of these sectors. So, from health to aged care to NDIS, they can be a little bit flexible if they choose. The businesses that are setting up have a little bit more flexibility, a little bit more innovation, talking to each other. The invoicing system is almost the same for everybody, that it minimizes that ability to overcharge. Let's call it overcharging. It can improve the outcomes for the clients, the people receiving the services. It could also make navigating of all of the care systems that are in this ecosystem so much easier. I've talked to that. Encourage collaboration and innovation. So, where the NDIS, where the people that specialise in NDIS can talk to the health system and go, well, hey, if we got together once a month and did something like this, or aged care or an NDIS, or all three got together for the benefit of the ongoing education of staff and support, but also the quality service that's provided. And that's where that quality assurance and governance comes in that we talked about earlier. And then also the better outcome for the clients and that connection, that people don't feel so overwhelmed or feeling left out, feeling like they don't know what's going on. So these are just my ideas. This is just how I think that we could create an amazing care ecosystem for people, and I think that it has a strong potential. But this is just my idea. So I'd love your thoughts. I'm just putting this up in a few different places, and if I ask questions, I always come up with an answer as well. Just food for thought.